So thank you very much for the opportunity to present today. I have no relevant financial disclosures. We're currently seeing an epidemic rise of high myopia globally, but as you can see from these epidemiological studies, that rise is particularly accelerated here in the Asia-Pacific region. So it's quite timely here at APAO to be talking about some of the complications of pathological myopia. And for us as retinal surgeons, we're not just going to be faced with more retinal detachments, we're going to be faced with more of the issues of myopic traction maculopathy, which is the content of my talk today. So myopic traction maculopathy, as we all know, is a relentless and progressive condition that starts with VMT or VMA. It then progresses into foveoschisis, eventual foveal detachment, foveoschisis, and then myopic macular hole formation, with the end result of macular hole retinal detachment. And this is due to a combination of both tangential traction as well as anteroposterior traction. And Barbara Parolini very nicely classified this in her publication a few years ago, where on the x-axis you've got tangential traction, on the y-axis you've got AP traction, and this allows you then to not just classify the type of traction that you have in your MTM, but it also determines whether you need to do a vitrectomy with macular buckle or just macular buckle on its own. And macular buckles have been around for quite some time. There is a poor uptake in the technique, I think, and particularly where I'm from in Hong Kong, there's and now a little resistance, I think, generally towards even the fellows wanting to do buckles. But I persist with this because I think it is a technique that works very well for patients with MTM. And macular buckles are by no means new. They've been around since the late 50s. In Hong Kong, the only ones we have available are the L-shaped Parolini macular buckle and the AJL macular buckle. And even with the AJL, it wasn't until about 2 years ago that we had the import license approved, and we managed to convince a distributor to actually start importing these buckles. So here is a typical case of an AJL buckle. It's a very standard approach that I use. I put a chandelier light into the end of the buckle so that I can then, once the buckle is in place, transilluminate where the end of the buckle is. And as you'll see shortly, we can move the buckle around so that the transillumination is right over the area of the myopic macular hole. And once we positioned it, we then just simply suture it in place. It's actually, if you're a good buckle surgeon, this is a very simple technique, and as you'll see shortly from my results, highly effective. One of the questions that I had quite early on when I was adopting this technique was really how much functional improvement do we get once we've implanted a macular buckle. And we seem to get very good anatomical results, and visual acuity doesn't seem to be a good endpoint measurement for knowing how well the macula is improving its function. So I decided to do multifocal ERGs on the patients at baseline, and then compare those to 1 month, 3 months, and 6 months post-operative after the macular buckle had been performed. And we also had a series of cases where 4 of them that would just happen to be the next 4 consecutive cases that I did macular buckles on were compared to a control group who were age-matched, also high myopes, but with no macular pathology as a means to control. So at this time, and this was data collected more than 2 years ago, we were using the Parolini macular buckle. And for those of you who may not be familiar with this technique, this is actually a macular buckle that we make in the OR. So we take a 5mm sponge, we put a hole through the middle of the sponge, and we push into that a titanium plate. We then slice the long arm of the buckle, as we call it, into a slightly slimmer shape so that it can fit around the eye. And then using the titanium plate, you can bend the buckle into an L shape, and hence its name. All of the patients had this L-shaped macular buckle together with a vitrectomy plus minus further ILM peeling and gas. And for the multifocal ERG, pretty standard 61 hexagon ERG from the Virus system. The results were that all our patients had previous failed macular hole retinal detachment surgery, so these were eyes operated on at least the second, if not the third time round. They all had long axial lengths and obviously high degrees of myopia. But even really large myopic macular holes, as the one that you see here, could be successfully closed using this macular buckle technique. We found that with foveoscisis foveal detachment, it does reduce over time, but during the 6-month follow-up period, there was one case of foveoscisis that didn't fully go back to its correct anatomical position. Here's a slightly different case, foveoscisis foveal detachment following the macular buckle, and you can see 6 months post-operatively, it's resolved very nicely. So on to the multifocal ERG results, and what we found was that when we looked at the first order kernel responses of the MF-ERG, this, just as a reminder, is an outer retinal generated potential. So this is coming from photoreceptors and bipolar cells. We see a statistically significant difference, obviously, in rings 1, 2, and 3, because this is where the myopic macular holes and fluid from the macular hole retinal detachment lies. And thus there is a big difference in the amplitude of responses in those areas, both in the P1 and, as you can see here, in the N1 responses in rings 1 to 3 as well. One quite interesting finding, I think, is that when you look at the second order kernel responses, which is an inner retinal potential from the ganglion cells, you see a much more widespread disruption of macular function. So whereas the outer retinal dysfunction seems to be localized to where the pathology is, the inner retina seems to have a more widespread disruption of macular function. And when we then performed sequentially the multifocal ERGs postoperatively at 1 month, 3 months, and 6 months postoperatively, we found that on the first order kernel responses that the statistically significant recovery of amplitudes were seen initially in the outer rings, so towards ring 3 and 4, then later in rings 2 and 3, and then finally at the fovea at ring 1. So the recovery of function seems to, even though the whole of the macula goes flat immediately postoperatively, the recovery of retinal function seems to go from the outside of the macula inwards. And there are various theories that we can debate as to why that would happen. So in conclusion, the study, which is really just a small case series, showed here that after successful macular hole retinal detachment or foveoscisis foveal detachment surgery, functional improvement starts from the periphery of the macula and works inwards. The inner retina has more widespread dysfunction, and it does not recover as well postoperatively. And when we looked at all sorts of regression analysis to see whether any of these parameters are associated with visual acuity improvement, we found only the paracentral inner macular dysfunction on the multifocal ERG was correlated. With that, I thank you all for your time and attention, and I welcome you all to Hong Kong next year for AIO2026. Thank you.
Thank you, Dr. Marten. Yeah, there's one question that we'd like to answer is that how do you go about the decision making regarding offering a macular buckle versus vitrectomy ILM peeling in case of MTM? Is it based on axial length or some configuration of the OCT that you design?
Yeah, I've now actually, and I've spoken to Barbara quite extensively about her publication. This classification I've actually printed, and I now have it in my consultation office on the wall. And I actually use this as a means to decide which type of surgery to do. If you look at the bottom left of this classification, you'll see an example where you've mainly got traction, which is in the anterior posterior. And strictly speaking, those could be fixed without even doing a vitrectomy. You could just fix those with a macular buckle because it's the elongation which is the main tractional component. Likewise, if you go to the other extreme, which is the top right, where you've got only tangential traction and you have a myopic macular hole, those don't need a buckle. They could be fixed just with vitrectomy, ILM, peeling, and gas. And then obviously in between that, and the extreme example would be bottom right, you would be looking at a case of a macular hole detachment where both tangential and AP traction is the issue, so you would probably look at combining the two surgeries in those cases.
Yeah, I like your ERG result, but if the patient has a very severe glaucoma, and we wonder if this patient is for the vitrectomy or something, ILM peeling. But in that cases, I think the macular buckle is indicated because it is used without vitrectomy. In that case, we should remove the anterior chamber fluid and lower the pressure, and we can select the location of the buckle. Because with vitrectomy, we can lower the pressure to see where is the buckle, but this macular buckle merit is used without the vitrectomy, I think.
It's a really excellent point, and I'd like to add to that I think the current HAL design, the buckle is too high. It's got too high a dome on it, so we actually get too much pushing upwards. And what I find with the Paralini buckle is that it's actually a much flatter buckle, and we see on the OCT that the retina's kind of got a flatter profile on the macula after that buckle, whereas with an AJL, it almost goes convex, it goes the other way. And I think that's kind of overcooking it. I don't think we need quite that much pressure from the buckle. I think we just need to relieve the traction a little bit, and then usually we get anatomical success. So yeah, absolutely.
Some surgeons complain that it's difficult to fix or locate the buckle, but if we remove the anterior chamber or lower the pressure with vitrectomy, so the buckle is spontaneously under the staphyloma, I think, yeah.
Absolutely.
My institution is Dr. Ando's institution, so
yes,
the,
absolutely, yeah.
a lot of
the Ando
experience.
Prom was obviously a very, very famous buckle, yes. But that's a great technique, so lowering the pressure and allows you to mobilize the buckle better. Yeah, thank you for that.
Thank you very much.